Okay, so we need to talk about a couple of sort of semi-specialty views. By specialty, I'm talking about they're not exceptionally common. Most of the hospitals don't do obliques, and if they do, they only do one. And it's the easier one of the two. And my elbow doesn't articulate the way human elbow does, but you know, I'm hoping to be able to show what it is that you see on both of these. So if you're shooting, you know, if you just shoot a straight AP of the elbow, like we looked at before, what you're going to have, can y'all see okay from over there? Okay. Then what you're going to have is some superimposition of radial head, right? So radial head fractures are not uncommon, so sometimes we need to be able to visualize the radial head. So sometimes also you can have a cornoid process fracture, just a little chip fracture off the anterior most superior portion of the ulna. So we need to be able to visualize that as well. Unfortunately on the lateral, both of those things are superimposed. Just can't see them all that well. On the AP, they're going to be superimposed on themselves or each other, depending on which bone you're looking at. So what we're going to do is probably the more common of the two fractures will be the radial head fracture. So what we're going to do is obliques. And the obliques, again, 45 degrees. And it's kind of a rough estimate, you know, because what you're trying to get at 45 degree angle are the humeral condyles. So the medial condyle is not hard to feel, right? But the lateral condyle is a little bit more difficult to feel. So how you get it to 45 degrees is, again, kind of a rough estimate. So what we're going to do is either, from the AP, we're either going to internally or externally rotate it. So what we're going to get then is if we've got superimposition here, then if we internally rotate, what I'm going to do is I'm going to take the patient from an AP and I'm just going to supinate the hand, right? So I'm going to internally rotate until the hand is supinated. That should put the humeral condyles at a 45 degree angle. Okay, so don't get out a protractor and see if you can figure out, you know, the exact 45 degree angle for this. Just supinate the hand. Okay, what that's going to do in supination of the hand is it's going to take the elbow and it's going to oblique it just enough. Let's see if I can rotate this the proper direction so that you can see the cornoid process, and you can kind of, not really, it's too tight, but you can kind of see where you're starting to see a portion of what leads up to the cornoid process. So if this wasn't so snug, I think this guy's got some severe arthritis, has no joint space left at all, then you should be able to see the cornoid process here. Okay, so that's the internal rotation. With the external rotation, what you're going to get is from here, we're going to get de-superimposition between the radial head and the ulna. Okay, of the two, the external rotation is probably the more common. Okay, so I've worked in hospitals. You can see it on page 196, internal rotation. You see that little pointy thing? Let's see if the slideshow included. Yeah, that pointy thing right there. Okay, so that's internal rotation, medial rotation, and that's what it's going to show you is cornoid process. With the external rotation, you've got, the de-superimposition here. All right. So the external rotation of the two is more common in my experience. Again, some of your hospitals may include both. They may include, for every elbow, it may be a 4-view elbow. AP, lateral, internal, external rotation. I personally have never worked in one of those hospitals. I've worked in hospitals where there was 3-view, and it was AP, lateral, and external rotation to show the radial head. Okay, so internal rotation, again, what are you going to see? Cornoid process. External rotation, you're going to see the radial head. Free of superimposition from the proximal ulna. The other thing, again, honestly do not know if this is going to be on the test. Mindy's redoing the tests. But if you look on page 202, this was not in essential projections on the front end of the, this portion of the PowerPoint. But this is what we refer to as a radial head series. Okay, so it's a series of 4 laterals of the elbow with the hand in different positions. Okay, and because you've got that superimposition of the radial head on the proximal portion of the ulna, you can't see it free of superimposition. Then what we're going to do with this is we're going to shoot with the hand in different degrees of rotation. Okay, so it's true lateral, but we also, if you can get it, have a lateral with the hand externally rotated, one with the hand pronated, and one with the hand overly pronated to where the lateral side of the hand is down. Okay, so it's 4. If you happen to see this on the test, if it's on the test, that's what it is. It's a radial head series. It's 4 laterals with the hand in different positions. Okay, and it probably is not going to be real specific to what the positions are, but that's what it is. It's a lateral with the hand in 4 different positions so that you get a complete view of the radial head free of superimposition from the ulna. Okay. All right, so next we're going to go to the humerus, and that's going to be on page 210. So you got a couple of options for the humerus, and depending on, again, whether or not the patient can really do what you want them to do, your projections of the humerus, you're going to have a little bit of critical thinking and a little bit of, use a little bit of triage and determine what the patient, what their likely condition is. Okay, so again, you got a patient with humeral fracture and they come to you again holding themselves. They may be in a sling and they may be just holding their arm, kind of like they've got an elbow issue. So the problem that you get into with humerus is that, again, we tend to lock ourselves into specific projections. If you look on page 210, what do you see for humerus? What do you see?
A lateral.
You see a lateral, and there, projection-wise, you got some options, right? So let's say the patient comes to you and they're holding their arm like this. Can you see something that's inherently wrong with shooting AP if their arm is across their belly like this? Can they get an OID of the whole thing? More the distal end, right? So, yeah, it's going to be tilted. So that's going to give you what we refer to as foreshortening. So in distortion, we have 3 things. We've got, well, that was kind of cool. We have size distortion, which is just magnification, and we've got foreshortening, which is tilt of the anatomy. Okay, so if the patient comes in, they can put their shoulder up against the image receptor, the wall bucky, but their hand is across their stomach, then you're going to have that increase in OID on the distal end. You're going to have foreshortening, distortion. So if the patient presents like this, they say, I can't put my hand out on my hip. This is, I mean, that would put everything parallel to the image receptor, right? If they could just abduct and get their arm off of their belly, then everything's parallel with the image receptor. But if they're here, what would be a better method? PA, yeah, turn them around. And you might have to oblique them a little bit, just a little bit, in order to get it, reduce the OID. But you can shoot a PA and avoid that issue with foreshortening, okay? So whatever position the patient's in, you can ask them, and it's probably going to be easier just if you ask them, can you put your hand on your hip? And if they do, then great, you're golden. But if they say, no, I cannot, it's probably a good idea to turn them around and shoot a PA. If you do that, make sure you mark your image that you shot a PA so it's not confusing when it gets to the radiologist. They think that you shot an AP of the left and a lateral of the right or something weird like that, okay? So, but if your patient can do it, what we're going to do is we're going to, for the AP, will externally rotate until the patient's in true anatomical position. All right, so in your evaluation criteria, what you're going to see on your different rotations is what specific anatomy you're going to see. All right, so externally rotate so that, the patient's standing in an anatomical position, or if you're on the table, you're going to supinate the hand, right? And what that's going to give us is, in the external rotation, we're going to see our greater tubercle in profile. So what's profile mean? Side view. Yeah, you're going to see it out to the side, So you're going to see your greater tubercle laterally. There's the thumb, so we're going to see it laterally on the outside. So what you're going to do is you're going to follow your thumb as to what anatomy that you're going to see. So this assumes that the patient can rotate, maybe it's follow-up from surgery, whatever. They can rotate, they're otherwise pretty healthy, and they can move around. So follow the thumb. If it's an external rotation, then you're going to see the greater tubercle on the lateral side of the proximal humerus. Okay, what you want is the humeral condyles parallel to the image receptor, just like what we saw in the AP of the elbow, just like what we saw in the AP of the forearm. Okay, so humeral condyles parallel to the image receptor puts the greater tubercle outward, right? You're following your thumb, so it's going to be in profile on the lateral side. Internal rotation, we go from here to internal rotation, and what we're going to see is the lesser tubercle on the medial side. So now we're going to take our hand from supination and we're going to rotate it at 180 degrees, remembering that a lot of that rotation is coming from here. You're going to have a tendency to think, well, we want 90 degrees, right? We got AP is here, right? My thumb is there. Well, if I rotate to 90 degrees, that should be good, right? And the answer is no, because most of that rotation came from down here. It's not until you start to rotate beyond that you really get rotation on the humerus. So now you've got, again, follow your thumb, you got the lesser tubercle on the medial side. Okay, so that's your two rotations, providing the patient can do it. Right? So if the patient has a broken humerus, you got some issues. That's when, again, the patient comes in, they're holding their arm like this. Can you put your arm on your elbow? Or put your arm on your elbow. I hope not. On your hip. They say no, then you're going to shoot PA. But what position is the patient pretty close to in this orientation? Pretty close to lateral, right. So from the AP, what we want is the humeral condyles parallel to the image receptor, and therefore in the lateral, what we want is the humeral condyles perpendicular, right. So we might shoot them PA. The humeral condyle is pretty close to perpendicular here. All right, but they've got a fracture. So how are you going to get an AP? You've already got the lateral. How are you going to get the AP? The answer is you're not, really. You're going to do some things to get another view 90 degrees from it, but fundamentally you're not. Okay, so let's say the patient has a fracture. You took that lateral, and you can see the fracture. Maybe it's mid-shaft fracture or whatever. And if it's mid-shaft bayonet fracture, you don't want to have the patient rotating, right? So one thing that you can do is maybe put an apron on the patient, take your image receptor and slide it up under the patient, still across their arm, slide the image receptor up under their arm as far as it can go. Okay, have the patient hold it there. Now you're going to be shooting, straight across, essentially into their body, which is not ideal for the patient, but neither is having a broken humerus, right? So you're going to shoot directly into the image receptor from the side. That kind of gives you a 90 degree, but there's a problem with this. What's up here? The rest of the shoulder. So you're going to show the entire humerus with this? The answer is no, you're not. So you've got a couple of options to show the proximal humerus. Wish I had a skeleton down here. My opinion, the best demonstration for the proximal humerus is what we refer to as the Y view, and this is kind of getting into shoulder. Find the page. Since I'm there, go ahead and mark page 234, because we're going to get to that in a minute. Y view. No, that's outlet, which is really Y view with an angulation. There we go. Okay, so on 240. On 240, what you see, the topic there is scapular Y, okay? And what we're going to do with a Y view is, let me pull this one. I think on the video I posted the other day, drawing on the lettering, it just didn't show up all that well. But your scapula has different features to it. So it's got a body, and the body is kind of vertical, like this, okay? And then it's got two projections we'll talk about here in a minute. One goes in one direction, and one goes in the other direction. What does that look like? Looks like a Y, yeah. So funny that we actually have something that makes sense. A Y view looks like a Y. So what we're actually accomplishing here is, what we're looking at is the scapula vertical to the image receptor, or perpendicular to the image receptor. So it's kind of like a lateral view of the scapula. All right. So this area right here is what we call the glenohumeral joint. So that's where the humerus articulates with the scapula. All right. So that's a little bit bigger than that, but let's say it's there. Well, let's say the joint space is here. The humeral head, let's say, is that big. Okay. So the humerus is going to hang down on either side of it. And realistically, your scapula, if you position properly, is going to appear much more thin than that. So what we can do is this position that we call the Y view. And with a Y view, what we're going to do, you can shoot at AP or PA. Most people shoot at AP. I always shot mine PA, and the reason is because with PA projection, you have less magnification, less OID. We used to use films, and it was harder to get the scapula magnified on a 10 by 12 film PA, or it was harder to get it on AP than what it was PA. With these great big image receptors, you got more flexibility. So what you're going to do is, if you're shooting at AP, you're going to oblique the patient up, and you're going to be shooting for the elevated side, okay? And your objective is to try to get the scapula perpendicular to the image receptor. What you'll see on the scapula, we'll take a look at it here in a minute, is that, you know, the bones are never as simple as this. You know, it's got features and projections. And on the back side, you've got this ridge, and then underneath the ridge, you've got this kind of like a cavity where you've got muscle, fat, and all this other kind of stuff. So what you'll do in order to position for this, and positioning is going to depend on a lot of things, patient's body build, whether or not they're kyphotic, how old the patient is. It could be anywhere from 45 to 60 degrees. Okay, so that's your first deviation from 45 degrees. It can go anywhere from 45 to 60 degrees, depending on the patient's, you know, their body build. So what you're going to do is you're going to oblique the patient up, and you're going to put your hand directly on what would be their shoulder blade, okay? And put your hand to where it's perpendicular to the image receptor, okay? So put your hands perpendicular to the image receptor, and that's going to put the two borders almost superimposed. But you've got that, you know, that soft tissue area that kind of makes it a little bit oblique. So you're going to have to do a little bit of an adjustment. Now the book, and even the Martinson book that you'll get next year, will tell you to take your fingers and put your fingers on the vertebral border, the border that's closest to the vertebra, which is real thin, and the axillary border, and then oblique the patient until your fingers are superimposed. That's going to be really, really difficult to feel, especially the axillary border. So what you're going to do is you're going to oblique the patient up until your hand is perpendicular, and if you're AP, then just rotate the patient back maybe 5 degrees. It's an estimate, but rotate them back about 5 degrees. Okay, and that's going to compensate for that hollow spot in the soft tissue that's going to give you a false impression with your hand, you know, being perpendicular, that you've got the scapula perpendicular. Okay, if you shoot at PA, you're going to be the oddball in the department. Trust me, I shot mine all PA, and nobody else did, so I had to mark mine. So if you shoot yours PA, make sure you mark it that you shot at PA, so that they don't think that you gave them the wrong Y view. So what you're going to do is you're going to take the downside, you know, you're going to oblique the patient up from PA towards lateral, and then oblique them back and do the same thing. Put your hand on their shoulder blade until your hand is perpendicular, and then roll them back towards PA about 5 degrees. It'll be beautiful. Okay? So again, your degree of obliquity is going to be determined primarily by your patient's body build, and you know, there's a range there. All right? So I went through all that to say, could you make a diagnosis of broken humerus off of that?
Mm-hmm.
Yeah, absolutely. Humerus, for the most part, if you position properly, the humerus is going to be larger than your scapula. So unless you're dealing with kid bones, the fracture is going to go all the way through. So even though you've got superimposition there, you're going to have areas that you should be able to see. You know, it may be a spiral fracture or whatever. You should be able to make a diagnosis. In addition, that's a big, heavy bone, right? So you probably are going to be able to see the fracture line through it. So Y view, that's my preference. But there is another way to get a good image, or not a good image, an image of the proximal humerus. Again, what we're talking about here is a patient with definitely a broken humerus. You can't get them to rotate. Now we're going to flip back over to page 234. And we're going to do some things. All right, 234, let's go actually back to 232. Yeah. 232, or 233, I'm sorry. So this is transthoracic. All right, what does trans mean? Across. So this is going to be across the thorax. Now, again, you've got a patient with broken humerus. You shot the AP, or you know, you shot the one with the patient's arm across their stomach as if it was AP, right? So now you got to get to 190 degrees from me. So you shot this one for the distal end, right? You stuff this up under for the distal end. Now you got to get something for the proximal. So what you can do is do a transthoracic. You're going to be shooting across the thorax in order to visualize the proximal humerus is closest to the image receptor. So you want to put it close to the image receptor, you know, to increase sharpness, recorded detail, no magnification, all that kind of stuff. So you put it up against the image receptor, you elevate the unaffected arm, get it out of the way, put it on top of their head, have them hold on to whatever, just get it out of the way. So what you're looking for is a proximal third of the humerus. So adjust your image receptor, you know, 1.5 inches above the downside shoulder, whatever. You're looking for the proximal third. The problem with this is that you're going to have 2 sets of ribs, 2 lungs, and a mediastinum projected directly over the image receptor, or directly over the anatomy of interest. Okay? So everything that we ever told you about motion right now goes out the window. Okay? So when we did a lateral chest x-ray, what we do? Breathing wise. Deep breath in, hold your breath. When we did a PA chest x-ray, what we do? Deep breath in, hold your breath. When we did abdomen, what do we do? Yeah, hold your breath. You know, depending on your radiologist, maybe inspiration, expiration. So what are the 2 types of motion? You got voluntary and involuntary. So if the patient can't hold their breath, what do you use? Short exposure time, right? None of that applies here. Okay, so what you're going to do is you're going to position the patient in true lateral. Whatever position their hand was in for the AP or the PA, you're going to leave it there. You're going to turn the patient 90 degrees, elevate the unaffected arm. You're going to set a long exposure time, so like 3 seconds. I mean, your minimum exposure time is going to be 1 second, but as much as 3. elevate the unaffected arm, have the patient breathe throughout the exposure. All right, and what that's going to do is it's going to, the humerus shouldn't move that much, but all the lung markings are going to move and all the ribs are going to move. So hopefully you can see a better image of the humerus itself. So, what was my book? 253, I think is where we were, was it not? No, 234. So if you look at the images on page 234, what you're going to see is the humerus, and it's not that it's bad, but is it good? Really? And if we're looking at the humerus, let's don't see that. Where's my humerus? And okay, apparently I don't have any images of humerus in here. It's not all that good, you know. You got motion, it's fuzzy image, you know. Especially the one on the lower end is, you know, you've got density differences with the you know, trachea over the top of it. It's a mess, right? You can do that. And it's a big dose to the patient too. You can do that, or you can do a wide view. My preference is wide. Again, your mileage may vary. If you want to do transthoracic, have at it, but I'd much rather do a wide view. Okay? So that's humerus. Any questions on humerus?
Is transthoracic going to be on the test?
Oh yeah.
It is?
Yeah. Oh yeah. Yeah. Maybe it's further down because it can also be used as a shoulder projection. There it is. Yeah. It's just a fuzzy mess. Yeah. So the things to remember about transthoracic is long exposure time, have a patient breathe throughout, right? And it doesn't matter if the patient's laying down, standing up, whatever, body position wise, you know, projection's gonna be lateral, and just have them breathe. So minimum exposure time, and the reason I'm pounding minimum exposure time is sometimes you'll have to use a portable to do this, and you can't get more than 1 second on a portable. So you're gonna have to minimize your KVP and increase your mass in order to get that 1 second exposure time. And in those cases, if you can't get less than 1 second, what you're gonna have to do is you're gonna have to tell the patient, I want you to take in a big deep breath and slowly blow it out and shoot in the middle of their exhalation. Okay, so preferably about a 3 second exposure. So any questions before we go into shoulder girdle? Drop that back down. Okay, so shoulder girdle, some of the projections here again are going to be very similar to what we looked at in the humerus. Fundamentally, the only difference between AP and lateral of the shoulder and AP and lateral of the humerus, providing the patient can do the rotation, again, is central ray location collimation. Nothing different there. So we'll talk about the central ray location collimation, but you see the same things, the same anatomy is included. It's a little bit better without the distortion because of the divergence in the central ray, but otherwise they're identical. Okay, so the shoulder girdle itself consists of clavicle, that's collarbone, and scapula, which is shoulder blade. So you see all the features on the scapula here. Okay, so we got a couple of different articulations. Obviously the humerus articulates, and we talked about that a second ago, the head of the humerus articulates at the shoulder joint where we have the glenohumeral joint space, but we also have a sternoclavicular joint, and roll them back up to this. So we've got two joints where the clavicle articulates. One is the sternoclavicular joint, and that's this right here. This is the manubrium of the sternum. and this is the acromion. That's the acromion process of the scapula, and that is the acromioclavicular joint, okay? So the sternoclavicular joint is the only bony union between the entire upper extremity and the trunk of the body. So it's this fibrous joint right here that it does have some movement and some flexibility, but you know, that's it. That's the only thing that attaches the two together. So we're going to talk about shoulder separations, shoulder dislocations are two totally different things. And one involves dislocation of the humeral head, and one involves separation of the AC joint. So it's a acromioclavicular joint, and that's AC, what we refer to as AC joint. All right, so the manubrium, that is the articulation of the sternoclavicular joint, and then you've got the AC joints out laterally, and it just connects the upper limb to the trunk. All right, so the shoulder joint is diarthritic, meaning it moves really well. Synovial, ball and socket type joint, it goes in all different directions. The clavicle is going to be on there. You know, you've got the acromial extremity, which is kind of rounded, as opposed to the sternal end is real blunt, and then you've got the body. So it takes this kind of a U-shaped appearance, the clavicle is not hard to image, but it presents some difficulties because of where it is. You've seen how we can image the clavicle already. If you think about it, is there a projection we've covered so far that kind of isolated the clavicle? Lordotic chest X-ray, exactly. So that's essentially what we're going to do to see. We can't get two views 90 degrees from each other with a clavicle. Just can't do it. So we'll get an AP or a PA. You can do either one, and then we're going to do an AP axial that's going to show us the clavicle. Very good, very good. So the scapula is a flat bone, and again, it's shoulder blades, triangular in shape, and it's got a lot of features to it. So really the features that we're going to focus on are the borders. So we've got a lateral and medial border. Superior border, yeah, we've got an inferior border as well. It kind of comes down to a point. But really what you need to focus on right now are the two borders, so that you can identify on your Y view if you've over or under rotated the patient. So what you have on the lateral border is kind of a fat, puffy border. That's also what we'll call the axillary border, because this is your axilla, so it's closer to the, to the armpit. And the medial border is your vertebral border, because it's closer to the spine. So it looks like that. And then we've got a couple of projections. This right here is what we refer to as the glenoid cavity. And then we've got the acromion process up here, and then we've got a corcoid process. Corcoid process, if you remember, is kind of like a beak-like appearing process off of the bone. So if I had a scapula down here, you kind of see how this kind of makes sense. It kind of looks like a crow's beak sticking out of the anterior portion of the scapula. So this is the anterior view. You're looking at the front of the scapula, corcoid process. And kind of superior and posterior to that would be the acromion process. Posterior surface there. All right, so all the same stuff, use your markers, patient instructions, all that kind of stuff. So I'm not going to run through all that. So our essential projections: internal, external rotation, and neutral position we'll add, and then we'll talk about a Grashey method. And sometimes some people have been around for a long time will refer to this as the true AP. It's not, but okay, if they want to call it that, that's all right. The Transthoracic, we already talked about. That's the Lawrence method, but we have another Lawrence method, and that is an inferior-superior axial projection. And it's often referred to as the axillary, again, because we're going to shoot straight up through the axilla. And then we've got the scapular Y view. And see, right here, it says PA, so why everybody does AP, I don't know. They're just all wrong. I'm right, right? All right, so we already talked about the rotations. External rotation, you're gonna see your greater on the lateral side. Internal rotation, you're gonna see the lesser on the medial side. So the neutral rotation is going to be, you just put the, you know, if you have a 3-view shoulder and they call for this, you're just gonna put the patient's palm up against their thigh. Okay, so it's not, the hand isn't supinated, it's not, you know, pronated, internally rotated, externally rotated. It's just gonna be up against the thigh, that's neutral rotation. Okay, so what do you see on neutral rotation? Nothing really. You know, I'm not real sure why we use it, to be honest with you. So in each one of these, what we're going to do is we're going to put the central ray 1 inch inferior to the corcoid process. So take a look at the patient. Look at a few things. You know, look where their manubrium is. There's no reason to have your collimation any broader than the middle of the manubrium. So, you know, everybody got a goozle, right? Where your soft tissue goes right there. Okay, so just find that and go just below that. That's the middle of your manubrium. Okay, so let's say we're shooting my left shoulder. My central ray should not, or my collimated field should not go beyond about the middle of the manubrium. Okay, so the corcoid process, I'm not going to do this because, you know, I'm an old man and not in all that great a shape, but you can tell where the corcoid process is. If you just kind of expose the patient's shoulder, that's where the deltoid comes in and it kind of plugs in right there. And, you know, you got your pectoralis majors, they come in and they kind of fold under right there. So if you expose the patient's shoulder, where you've got the shoulder that comes in and folds and the chest that comes in and folds, and you've got that soft tissue indentation right there, that's where your corcoid process is, okay? So that's where your central ray is going to go, about 1 inch below that, okay? So if you go 1 inch below that, open your collimation to about the middle of the manubrium. That should include the soft tissue on the outside. And then open it up till you see, you know, collimated field directly on your image receptor, and that should be low enough to get you the bottom of the scapula, okay? 1 inch on all three of those. Your central ray is going to be 1 inch below the corcoid process on all three of those. So your radiation field, you know, I know in lab they want you to use separate image receptor sizes, and they want you to put them in the bucky or, you know, whatever, you know, if you're doing it just whatever. They want you to put them in the proper orientation, right, to give you an idea of what your collimated field should be. So your collimated field in this case is going to be crosswise. So what you're looking at is 12 inches this way by 10 inches this way. So if they give you a 10 by 12 image receptor, the old screen film, it's going to be going this way. Obviously behind the patient, not on top of them, but behind the patient, it's going to be going crosswise, okay? So 10 by 12 crosswise is what you're going to be looking at. So this is internal rotation. We can tell it's internal rotation because we see the lesser tubercle on the inside. External rotation, we see the greater tubercle on the outside. Exactly. And then neutral rotation, we laid an egg. Yeah. So. All right, so the Grashey method. The Grashey method is to show the glenohumeral joint space and show it open. All right, so what you notice on all those other ones, this is the joint space. So your scapula sits at an angle, right? So your angle's going out this way, and you've got superimposition. You know, let's say our joint space is here. We've got superimposition. You just can't see the joint space open. You've got superimposition. So what we're going to try to do is get rid of that superimposition. So we're going to rotate from AP towards the side of interest. Okay. So our Grashey method, back down to it. That's what we're looking for. So we're going to rotate the patient, I want to say it's 45 degrees. Somebody on it? 35.
It's 35 to 45.
35 to 45 degrees. All right, so rotate towards the image receptor 35 to 45 degrees. And again, what we're looking for is the glenoid fossa, so we don't have to focus and we don't have to have the collimated field that we had previously. Okay, 45 up to 60 degrees. Okay, I found it. It's 229. So on 229, if the patient is in a recumbent position, the body may need to be rotated more than 45 degrees up to 60 degrees. All right, there we go. And that's what we should see. And again, we don't need to see as much, we don't need as broad a collimated field as what we needed for the rotational. So we're going to focus right on the joint space, and we don't need to see all the way through the maneuver. Okay? Transthoracic, we already talked about. All right. Okay, so the other Lawrence method is what we refer to as an axillary, and that's on page 235. All right, so it's an inferior-superior projection, meaning it comes from below and exits the top. And we're going to have a number of different things we're going to have to accomplish with this. First off, I've tried to do this standing up with zero success. So what I've done is taken the image, or taken the x-ray tube, and I've pointed it straight at the ceiling and tried to have the patient lean out over it. Didn't work at all. I've tried the opposite of this, which you'll see in the textbook, shooting inferior projection, also zero success. All right. So the only thing I've personally had success with is the true Lawrence method, as you're seeing on page 235. So lay the patient on their back, and what you're going to do is you're going to, you've got a, this is kind of a stretch. You're looking at me from the ceiling, okay? So what I would be doing is laying down and putting the image receptor above my shoulder, okay? So if the patient can abduct their humerus out to 90 degrees, you can have them hold the image receptor like this. Or like you see in the textbook, you can have them, you can tape it up, or you can put it on a image receptor holder, whatever you need to do, right? But it needs to be pushed into their neck as far as possible. If the patient can get their arm to 90 degrees, then that's ideal. And then you would angle your central ray 30 degrees towards their head. Now, what's it going to hit? We're going 30 degrees this way. What am I aiming straight at? The head. Specifically what do you want to protect? Thyroid and eyes. Yeah, your eyes. Right. So can you do something? You can't do a whole lot about the thyroid, but can you do something about the eyes? Turn your head. Exactly. Have the patient turn their head. And watch what happens when I turn my head away from the central ray. What happened here? Can you see it? You can push the hour in further. So you're going to get two things out of turning the patient's head. One is you're going to get more room for your image receptor. If you have a patient looking straight ahead, there's a very good chance you're going to clip the head of the humerus. Okay? So if you turn their head, you protect their eyes, and it gives you about another ½ an inch that you can push the image receptor in to hopefully not have that happen. Now, a lot of times your patient can't do this. If they truly have a shoulder injury, they might not be able to abduct out to 90 degrees. So your angulation is going to be dependent on how much abduction the patient can have. So if they can't abduct to 90 degrees, you're just going to decrease your angulation. Your central raise is not going to change, or your image receptor position is not going to change, but I can't do both, right? So if the patient can't get out to 90 degrees, and let's say they're at 60, your angulation may only be 20, something like that. Okay, it's non-specific. You're just going to decrease your angulation if the patient can't get to 90 degrees. Okay. It should look like this. So we'll go through. This is really not the best image of a axillary. But next semester or next year, when we go back through all this, we'll take a look at this and see what exactly what it should look like. And it's passable. Don't show any kind of pathology on. It's just not ideal, but it'd show any kind of pathology in the joint space or the proximal portion of the humerus. Okay, so we talked about the Y view, 45 to 60 degree oblique. Any questions on Y view? I mean, it looks like that. Oh, one thing. Okay. So we've got two different Y views. One shows us, humeral issues, and one shows us the scapula. Okay. Positioning wise, obliquity wise, and what you want to see in the scapula itself are identical in both of them. The only difference between the two is position of the humerus. And you're looking at that. Could you make a diagnosis of the humerus? Well, you got humerus here and here. So if you got a fracture, would you be able to see it? The answer is yeah. And then you've got the scapula, and you've got, all this coming up through here, but you've also got some over here. You got a lot of superimposition down there. It'd be kind of tough to make a diagnosis of the scapula, right? How could you make this image better for the scapula? Move the humerus out of the way. Right. So the only difference between a Y view for the scapula and a Y view for the humerus is position of humerus, right? So let's say we're shooting AP, and you're looking for let's say a humeral fracture. The humerus is just going to be hanging down, right? Or the patient's going to be holding it. But if you're looking for a fracture of the scapula, which is miserable, by the way, if you're looking for a fracture of the scapula, you just move the humerus a little bit, and it doesn't really matter which way, whichever way is most comfortable for the patient. Just get it out of the way a little bit, right? That's the only difference between the two. Otherwise, they're identical, okay? So the difference is going to be position of the humerus, right? So if you're looking for a scapula, move the humerus. If you're looking for a humerus, don't move the humerus, right? Okay? Don't miss that. Oh, and that's another, thing to pay attention to. If I say don't miss that, that generally means, yeah, so last edition of the test, yeah, that was a question. Okay, so we're almost out of time, but we're also almost out of projections as well. Clavicle, I may have to record in my office. So AC joints. So you got dislocation.